everyone, and welcome. We are so excited to have you here for yet another Zensible webinar. And today's topic is the effective use of digital tools for mental health. Now, let's start with a quick reality check. Did you know that over 60% of mental health professionals globally now use some form of digital tool in their practice? It is true. It could be an AI-powered therapy assistant or an automated assessment tool, or could even be for client engagement. Not only that, nearly 80% of clients have first turned to some online resource, whether it is a blog or a tool, before even speaking to a therapist. That means digital tools aren't just the future, they are the present. But this is the big question in everybody's mind. How do therapists use these tools effectively without using their human touch? And how do we ensure that what's helpful doesn't become harmful? And that's exactly what we are here to discuss today. Okay, to guide us through this conversation, we have somebody truly wonderful. Introducing our speaker, Soumya Choudhary. Soumya is not just a PhD scholar at NIMHANS. She's leading a groundbreaking project called MindLamp, which is transforming how individuals with schizophrenia receive care. She was also the head of research at Behavidence, a company which is at the forefront of digital phenotyping, which, if you're unsure, it is the science of understanding mental health through digital behavior patterns. Yes, it's as
हमें तो
cool as
खुलवाना
that
तो
sounds.
दुकान खुलवा लेंगे
Sorry, I'm going to mute you, Sonali. Right. But that's not all. Soumya recently spoke at Manotsava, where her talk on digital tools on mental health was so insightful that I knew we had to bring her here for a webinar at Zensible. And just to top it off, a few weeks back, she received an honor. She was awarded the Prominent Alumni Award by Christ University, her alma mater. So without further ado, welcome, Soumya. Thank you for being here with us.
Thank you. Thank you, Veda. It's my pleasure.
All right. To the audience, please feel free to keep the conversation going in the chat box. We love an engaging audience. We have kept aside the last 15 minutes for questions, but you can send in your questions at any point of time. Shreya will be collating all of these questions for us, and we will go through them in the last 15 minutes, no matter when you sent them. Okay, so keep it engaging. So let's start with the question on everybody's mind, Soumya. There are so many digital tools in the market today. There is a tool for mindfulness. There is a chatbot tool that helps with therapy. There are some AI-enabled tools that provide digital therapy. How effective are some of these mental health apps that are out there? And how do they compare with face-to-face therapy, according to you?
Okay, great question, Veda. And everybody, this is how I start most of my talks because this is the most concerning question that I get. There is nothing better than face-to-face therapy. No form of mental health app at the given point, and I think in the next 15 to 20 years can beat the effectiveness of face-to-face. Or the face-to-face doesn't mean the patient has to be in front of you. It can be virtual as well. The human touch of a psychologist cannot be beaten by any mental health app, whether it is with or without AI. What they help with is enhancing your face-to-face therapy. So if you are a psychologist and if you're doing therapy with the patient, if you are a clinician and you are trying to monitor progress of a patient, if you are a coach, a life coach or a wellness coach, and you want to know whether whatever coaching you're giving to the patient is working, these tools help in collecting data that can help with monitoring and symptom tracking, which is very difficult to do on a daily basis for a therapist, of course, because the therapist is not talking to a patient on a day-to-day basis. And that is where I see the best use case of mental health apps, whether with or without AI, because now there are so many new technological terms that you almost wake up every day and see a new term come up. Is So the best use case is to monitor progress, to help record mood, is to journal, and sort of report your symptoms at one place where you can't, because you can't talk to your therapist directly, and then discuss it with your therapist later on a later date, and the therapist in turn can probably track your progress in the given point of time. So they are effective in that sense. Now, if you ask me what the research says about it, there is something called an effect size when we do research, and an effect size would mean how, in a very simple term, how impactful is this? Is it impactful to a small level of population? Is it impactful to a moderate level of population? Or is it impactful to a high level of population, like a large number of people? So a lot of studies, when you look at their results together, which is called a systematic review, it shows that the effectiveness of these apps as a standalone intervention is small to nil. I mean, like, it only impacts a small group of people and can't be generalized to the larger population if used just as a standalone app. But if used in adjunct to your normal intervention that you would do as face-to-face therapy, that becomes moderate to, it still says small to moderate, but it still comes up to a moderate level, which is good enough for mental health research, and that is the gold standard usually. So even research is not very optimistic about just these apps. And I like to quote my mentor, John Torres, who always says that the era of self-help apps is over. Like, if you feel you can use a self-help app just for anxiety and not take professional help, that might not be the case, at least for the next 10 years, no matter how great the app is. So just to summarize, that answer is yes, they are effective, but they're not effective as a standalone app. They are effective to a moderate level when you use it in adjunct, like in addition to your normal interventions that you're doing.
Yeah. So that is really good, and that's what I have always felt, Soumya, that when it comes to mental health, that face to face, whether it is face to face, we are sitting next to each other, or virtually, that interaction is really, really important. But some of the self-help apps that are out there, not just in India but worldwide, they cite that there is a lower number of therapists who are available, and therefore, to ensure that care is available to everybody, these self-help apps will be useful, and that translates really to a large extent in India, where mental health is still stigmatized. People don't want to come talk to somebody. Would it be better that they took the advice of a self-help app if they feel reluctant to come talk to somebody? So how true is it? First of all, is it true that the number of therapists who are out there, let's talk only about India, let's not go globally, is less? And can these self-help apps fill that gap?
Great question. So, yes, there is a definite treatment gap. And by treatment gap, I mean there are more people who need help and less people who are getting help, because there is a difference in demand and supply of like demand of care and supply of the people giving care. In a very interesting paper developed by some of my professors at NIMHANS, they said it will, for the current demand that India has, it will take us 72 years to build the human resource that we would need to meet the current demand. So to build a clinical team that can handle today's demand, we would need to be 72 years ahead. So that there is definitely a treatment gap. And is self-help apps the answer? Maybe not, because one thing first is India struggles with something called digital literacy. We assume that if everybody has a smartphone, they know how to use a smartphone, but that is not true. And I see it every day with my patients, and I've been seeing it from the last 4 years. There is some literature that says, okay, COVID enhanced digital literacy, COVID enhanced smartphone adaptation. It got more people to buy smartphones. It increased internet penetration. There were more areas in rural India that had internet, but it did not necessarily enhance smartphone use. So if you the one self-help apps will be effective if you use it. You will use it if you know how to use it, and that is a challenge. Second challenge with digital literacy is these apps are not always in local languages. You will have them in English, fine. You will have them in Hindi, most of it. Okay. You'll find very few apps in Kannada. You'll find very few apps in Odia, I'm from Odisha. You'll find very few in Bengali or other local languages. And then because the treatment gap is in the rural areas, right? It's most in the rural areas. It's most in suburban areas where people actually, like you mentioned, are stigmatized to seek help. And if they want to use such apps, is this the solution? And because of digital literacy, India might not be the best, well placed for self help apps. Having said that, there are a lot of these apps that are in local languages, are free to use, because that's another thing is cost. Not all these apps are cost free, right? They have an added cost to it. And you don't feel the need to pay like 99 a month for like a psychoeducation content. And if there's a self-help app that is in local language, is free and is useful, then definitely it can help alleviate some of the distress that the patient feels, but not necessarily replace care. The one thing that can actually help with the treatment gap is the telepsychiatry services that we offer, or that the country is offering through the TeleManas program, which is you call 14416, which is the National Mental Health Helpline number, and you have some symptoms of panic, some symptoms of stress, and you want to talk to a counselor and you're not able to reach a therapist at that given point. You call them and they will connect you to a counselor there and then in that same call, and you can request for a call back, etc. So you making use of India's telepsychiatry. So as of now, in the next, till we build up our app repository, using the telepsychiatry services will help in India's situation more with the treatment gap. And of course, use these helps, because even the Telemanas program uses certain sort of apps to keep the patient in touch. Even if you use other free apps that are like the Mind Lamp app, for example, if you are a patient, you can get it for free. And if you're enrolled in our program, there's a lot of psychoeducation content. It's completely self-help, right? You can have access the meditations and everything for free, but we see patients don't really use it. And that is where research comes into handy, because it tells you whether people are interested in using these apps or not. Second thing, one other point I would like to mention is these apps are helpful if you use them for a long period. And as you've heard me speak before, there is a direct drop in the retention of these apps. So the maximum amount a person has used an app is 13 days. Well, that's what research says. And after 13 days, they sort of either they forget about it, they delete it, etc. The only app that probably goes on for 30 days are the peer support apps, where you actually talk to a therapist on the phone, like a telepsychiatry app where you're getting direct synchronous help from somebody. And those types of apps have the longest retention period. So to summarize, that yes, the treatment gap is big. Self-help apps are not the answer. You would need more advanced self-help apps that can actually help connect the patient to the service, can provide some relief during that bridge time between when they can actually go see a therapist. And it needs to be cost effective, it needs to be culturally validated, it needs to be in the right language, and the digital literacy angle has to be sort of factored in. Meanwhile, telepsychiatry, in India's context, telepsychiatry is probably a better solution to help with the treatment gap.
Okay, all right. So we have taken the self-help apps out of there. So its effectiveness is questionable. Its longevity of use is also not validated. So let's talk about these hybrid models, right? You're saying that the hybrid model is what will help, where between sessions or before coming to session, the clients use that and then they bring that data over to therapist.
Yeah,
So how can therapists promote this sort of hybrid model so that they get the data, and when therapists themselves are they have to talk to so many people and they have a lot of work, how can they effectively gather the data out of these apps? Because clients will lose interest if they
right,
just enter their
right,
mood journal and the therapist does not ever see it. They also lose that motivation,
right,
right?
right,
So
right,
how can you integrate that both? What do you
right.
suggest to therapists that they do as part of their practice?
Right. A great question. And this is what my research is currently looking at, is a hybrid model of care to support to extract the maximum potential out of digital mental health apps or digital psychiatry in general. And what does a hybrid model mean? It's something like a guided meditation. So you have guided and unguided meditation, right? Unguided meditations are like self-help apps. You play a video and you're just supposed to, like, there's some tune playing and you're supposed to meditate, but you will never get rid of your thoughts because your thoughts will always take over unless you are like an experienced meditator, if that's a word. But
It is a word.
thank you. But in like guided meditation, there's somebody telling you what to sort of do step by step to maximize your meditation outcomes. Similarly, hybrid care models are like that. You will have a person always checking on you to make sure that you're using the app. If you need any technical help, because as I said, not everybody is a tech expert. Even in Bangalore, like there's a patient of mine who was like, hey, ma'am, I'm from Bangalore, I know how to use the app. And then he had the most amount of technical difficulties. So it's not a given that everybody will know how to use the app. So the role of a digital navigator, and I'm actually actively writing about this role, something that I've learned from, again, John Torres and his team at Harvard, is this is the bridge between three important triangles. One is the patient, second is the clinician, and third is the technology. So if there is something bridging them, is this person called a digital navigator. And how do they do that? So let's say you are a therapist and you have a patient. You are really wanting to sort of use all these tools coming up, and you've personally verified two apps, one for mood reporting and one for, let's say, physical symptoms, like tracking like sleep, tracking heart rate variability, etc. Now you want to suggest this to your patients, but you're so busy that you never really have the time to sort of look at exactly the type of case that you told me, that I want to look at the data, I want to make sure that the patient is adhering to it, there is some sort of effectiveness to my suggesting the app. So you hire a person called a digital navigator, who, there are also trainings, by the way, we offer for digital navigator roles. It's a 10-hour free curriculum that can be offered to people to get trained in basic technological skills. And that person will onboard the patient for you, make them go through the app one round so that they know how to use the app. They explain what to do in the app and how often to do it. It's like giving a digital homework that therapists give. And they've left your clinic. Now this digital navigator follows up with the patient every week, asking them, with their consent, they will be calling them and asking them, are you fine, are you using the app well, is there any issues? If not, then please take these surveys because we are not getting any data from you, etc. At the end of 6 weeks, when it's their regular follow-up period, before the patient is about to come in, the digital navigator will discuss with you, the therapist, that I have seen that your patient has gone out less. He's reported symptoms of anxiety. He has also slept very poorly, and he's not taken any cognitive exercises that you had asked him to. Maybe this is an indication of some clinical signs, or maybe you take this as like additional layer of clinical assessments, and then you factor in your clinical judgment. That actually benefits a lot in in your therapeutic alliance with the client, because you know what happened in the 30 days or 6 weeks when the patient was not there, and there is no recall bias. So the patient doesn't have to really try to remember what happened over a period of 6 days, because you have that data. Maybe he slept well in the last 3 days and has forgotten that he slept poorly for 4 weeks, and those types of things will help you. And this model continues for every patient that you have. So this is a very small individual level scenario of a hybrid model, where you get one person to bridge the gap between the technology, patient, and clinician. And that person not just helps the patient, but helps the clinician in making sense of the data. What is the data telling? Like, for example, for my project, I am acting as a digital navigator slash clinician slash sort of a research assistant, where I try to help the patient use the app, and I see the data, and then I discuss it with the psychiatrist. I'm also discussing with other members of the team that this is the data that we're getting from the patient. Can we ask him to walk more? Can we ask him to sleep better? Is there some medication changes that we have done? Probably that's what's impacting his sleep, etc. So, to answer your question, is the best way forward for digital psychiatry, whether it is VR, virtual reality, whether it is wearables, whether it is smartphone apps, whether it is any type of asynchronous technological use, hybrid model is the model that will help with engagement, because that is the biggest challenge that anybody faces with these technologies, that there is no engagement after a certain period of time. Hybrid model will help with adherence, because if you help people engage with the app better, they will likely stick with the app longer. And it helps with clinical insights. So the whole point of this field is to get more data and use that data to enhance outcomes. And this person will probably do this model will extract the best out of the data coming in. So as hybrid comes in between either completely self-help or only therapist, right? So it sort of links the two. It gets you the best of both worlds. And at least for the next 10 years, till we have walking robots doing this job, this is going to be the best way forward for this field.
Yeah. The talking and walking robot therapist aside, let's talk about data, right? You said that data is the most important thing in this
Yeah.
field. I'm just curious. We are saying boldly that hybrid therapy is the right thing and it promotes adherence, it promotes therapy outcomes. Are there any research that backs this up? Do we already have some research that back
Of
it up?
course. Of course, there is a lot of research to support both my points. There is a lot of research to support that just apps alone don't work, um, which makes my debate clearer. That okay, if apps alone don't work, what works? And there is the research that these hybrid models work. For example, at my time at Harvard, I was actively involved with something called the digital clinic model. The digital clinic model by John Torres and his team at the BIDMC hospital at Harvard Medical School is where they follow exactly the case scenario that I told you. There is somebody who onboards a patient called the digital navigator, and the clinician sees the patient, and it sort of goes on for 6 weeks. So their therapy time is for 6 to 8 weeks. They get CBT, and the DN discusses the results that comes up with the clinician just before the patient is about to come in. And they've seen that the outcomes, or at least the adherence with the app or the use of the app, is better with these types of hybrid models as compared to no hybrid models. In fact, people reporting feeling more fulfilled with therapy with these types of models as compared to no DN models. However, with in all full disclaimer, there are people who don't like the DN check-ins also, because they feel they just want to talk to the therapist. So there is always the other side of the coin, and that's going to be there. But there is research, and I'm happy to share that with anybody who's interested in reading to support these types of models. Now, this is not just a case of mental health. There are peer support workers at NGOs. There are assistants at hospitals. There are different types of roles that are in similar capacity, just in different environments, where you have a bridge between a patient and whatever service they need. And if there is a layer of digital infrastructure involved, then you need that bridge to sort of smooth things over. So there are other concepts like this, but this, like for example, you have if you are going for an X-ray, you have the radiologist, you have the nurse, and then you have the technician, right? Because the technician is the one who looks at the report, does the tech work, sort of sees what it is, sort of gives it to the doctor, discusses it with the doctor, and then produces the report. So that was not a standard in radiology, by the way. So as radiology sort of came up, it became a standard that they need a technician, and the field adapted to it. Similarly, I feel digital psychiatry will adapt to the concept of a digital navigator uh, and a hybrid model, but there is research to support it.
Okay. Again, before we move on to the other cool thing that you mentioned
Yeah.
about wearables and VR, I have one more question.
Yeah.
So this digital support, does it help only if it is CBT, or it does not matter? It goes across modalities, no matter what the counselor or psychologist or psychiatrist follows. It goes across modalities, do you think?
Of course. See, in my experience, I have seen a lot of these apps call themselves CBT experts, because that is something that I feel. There is no research to support this. It's just my personal opinion as somebody who works in this field, is that CBT is very relatable to the public because it has become such a common word now. So everybody likes to say that, okay, we do CBT. Apps like to say we do CBT. And that has become also the easiest approach for CBT. If you go and Google Chat GPT, what type, and you talk to the AI and ask him to give you therapy, he will automatically assume that you need CBT and start giving you CBT. Just because it is such a widespread phenomenon, most of the apps say we provide evidence-based CBT, which is basically CBT is very researched. They just add the word evidence based. A lot of it is just marketing, but it does work across all modalities. It works across. There is something called acceptance and commitment therapy. There are a lot of approaches, which includes cognitive rehabilitation. So apps that provide you what we do with Mind Lab, right? We give cognitive exercises for people to improve their brain working memory functioning, cognitive functions. There are apps that do a lot of positive psychology, which is meditation, affirmations, etc. There are apps that do motivational interviewing for substance use disorders to sort of um, change from your addictive behavior and probably transfer into a normal behavior. So it works across all modalities, CBT being the most common one because it is easy to implement, but you will have a lot more out there.
Okay, thank you. That clarified it. So now let's talk about wearables, right? One of the things that you mentioned was India's digital literacy is a problem. They will have trouble using the apps, but the cost is a problem. But there are wearables like the Apple Watch. They have this state of life, smart of life. I forget the name of the app that actively collects your data that you can relate back to mental health, like your nervousness, anxiety. It identifies all of that, and then it collects the data and it gives it to you. So can we, instead of asking the clients to go through this, especially clients who may be digitally not so savvy, so that we can passively collect this information, where does such wearables come into picture?
Great question. So with wearables, what I have seen is it helps collect a lot of biomarkers, no? What you mentioned, sleep. It helps collect luminosity. How much is light? How much of light are you in? Are you sitting mostly in dark rooms? Are you in light rooms? How much outside are you going? Are you going out in daytime? Are you going out in nighttime? It collects a lot of activities, like how much are you moving your hands? How much are you walking? It helps collect something called galvanic skin response, which is how much electricity is being conducted through your skin, ECG, and a lot of these heart rate variability, a lot of biomarkers that can help detect symptoms. And they're related to disorders, but they're very overlapping. Now, wearables also are different types. There are like on body, there are inside body, there are close to the body, near body wearables. There's a lot of wearables. Now there is a term called wearable AIs, which is basically involving mixing wearables and AI to sort of predict patterns of the behavior. What Apple Watch does. Apple Watch, if you see something called their atrial fibrillation, like their ECG that you can take. There's a one lead ECG that you can take from the app. It goes through a machine learning algorithm to tell you whether is your heart rate normal, are there any signs. I see them mostly as purposes for monitoring of mental health. Research shows that their prediction capacity currently is not the best in all the research that is being done. It is not so. In machine learning, you have something called accuracy metrics that tell you how accurate the model is to predict the phenomenon that we want to predict, and the accuracy metrics are not something that are coming out to be very great for wearables, at least in the recent ones that I have read. But they are very effective in monitoring. Interestingly, very recently, I read a paper where for people who had bipolar disorder and people who had other forms of mood disorders, they're usually, if they're asked to do some sort of physical exercise, and then you go back 1 month later, they will report having done a lot of physical exercises, but the clinician will see no change. And the outcome from a physical exercise that should have come, that is not there. That is because of a recall bias, and you add a wearable on it. Now, if the same patient sort of wears a wearable, you know how much workout have they really done in that 1 month of period. So that validates the reporting to the clinician. And so what they are reporting is more accurate than what was just being verbally reported about their physical activity levels. That research was done very recently, and it was suggested that there was a significant difference in the group that just reported based on how much they actually had done, and the group who wore the wearables. So I feel wearables are very useful in validating what the client is saying about their physical symptoms. It is very useful if the patients need a little bit of motivation, because it sort of helps them keep on track, because you can meet your goals and you can set your goals, and then you see when you are in a low stress zone or in a high stress zone. Like, I have a patient who uses something called a Whoop, and that Whoop is apparently a new healthcare band which tells you you are in a low stress zone now, or you were in high stress zone. And that is very validating for him, because whenever he has anxiety, he feels he's overthinking, but when he looks at it, he feels, okay, actually was in an anxious state and maybe I dealt with it, and this is how good I feel about it. So wearable AIs are effective if we don't rely on them too much for predicting something. But if we want to integrate them in our therapeutic, along with our normal interventions, it can help improve therapeutic outcomes through providing constant monitoring, even when if physical activities are involved, especially.
Yeah. Okay, so that is a good point. You have the wearables. Before you come to the next session, the therapist gets access to that information, and they are able to analyze and say, what next do I give to this client, and they don't have to wait for the client to come and tell. They have the data ahead of time. So I was wondering, what you talked about the digital coordinator. How about we have these apps? Obviously, it will take time for this to happen, but we use AI to analyze this data and give a feedback to the therapist before the next session, that, hey, I've analyzed the data from their wearables or from their app usage or whatever, and this is what I see as the analysis. This is the result of the analysis, so that they can take it, or that it can be used as an assistant for the therapist, even to consolidate their notes, to provide summaries of what has been discussed with the client, not discussed with the client. So what do you think of the future of these kind of AI technology that connect the clients between session details with the therapist? how do you think that is going to work?
I feel that is the goal of the hybrid model, is to connect the tech and the clinician. Where does AI come is up to the clinician. Whether the clinician wants advanced level of information, whether the clinician wants just what they are getting from the app without any patterns. If the clinician is a researcher and he wants to group together a lot of the data coming in and then use AI, the insights that AI's use would be really dependent on the insights that the clinician wants from the data that is coming in at an individual level, at a group level. But we all know that AI is can also make mistakes. It is not that it cannot make mistakes, because there are nuances to a patient which only the clinician knows and the AI is not aware, because AI has no therapeutic alliance with um, the client. Suppose the wearable, I gave it to my brother to walk 10,000 steps. AI will think the patient has walked 10,000 steps. But the clinician knows that because the patient reported it in the therapeutic session that I was lazy. So just to meet my goal, I gave it to my brother to walk 10,000 steps. And those kinds of nuances are basically something that only the therapist is aware of and not the AI. And that is my only concern with AI, is the clinician. Actually, in one of your questions that you had sent to me earlier was, you had asked me, should clinicians fear the use of AI, or because they can be resistant to it? Being resistant to is natural, because it's uncertain about what the future holds. Will it replace me? Will it not replace me? All those questions are obviously there. But using AI in a balanced way should be what the clinicians should aim for in any sort of a model, whether they don't have the capacity to hire a digital navigator and they just want to sort of balance and use apps on their own, and they want their little digital assistants, which is like ChatGPT or whoever. And if they want to use AI, use it, but use it in a balance where your clinical expertise is always the top level of judgment that you're making when you're talking to your patient. And how intensely you want to use the AI really depends upon what insights you want to generate from it. Just make sure that the AI you're using is ethical. Let's say if you follow all types of confidentiality, all privacies, etc.
Yeah, that is true. Sorry, I have to mention this. At least you gave it to your brother for walking. In my previous organization, we had a walkathon, and people were suggesting, I'm going to tie this to my dog and make it run around. So, yeah, there are a lot of shortcuts that people can do when it comes to these sort of things. We have to be mindful of that. So
Correct.
that makes me wonder. So we spoke a little bit about the client with bipolar disorder doing a lot of physical exercise, but it's not manifesting as outcomes. You're not seeing the outcome. What sort of outcome tracking or progress monitoring do we have right now? And how can digital tools help in that outcome tracking and matching up with, hey, do we have to pivot and do something else? And where can AI, if at all, come into picture in this manner?
Correct. So the most amount of apps that we have are either outcome tracking, symptom tracking, or peer support. Those are the two main categories of apps that are available actively on App Store or Google Play Store. I am not I'm fully sure of what processes do psychologists in India. Probably a very interesting paper, if somebody is interested in writing, is what level of screening do they use to select the types of apps that they want to suggest to patients. Because there are many. You can use an app just for mood reporting, which will give you something called EMAs, that is ecological momentary assessment. Ecological meaning in your natural environment, momentary meaning in that moment, and assessment is assessment. So these EMAs are basically small surveys that you can take from an app. For example, PHQ-9, which is Patient Health Questionnaire, which sort of screens for depression. And they can take it on the app, where they can report, today I felt sad, today I felt helpless, today I felt anxious, today I felt paranoid, etc. And that will be there for the patient, for the clinician to sort of see and reference whenever they want. there is for mood reporting. Then there is for symptom tracking. Is there will be apps where you can report. Just click on the symptoms that you are feeling if you don't want to write it down, so that you don't have recall bias later. There are ones for water tracking, right? Like you have water apps where you can record how much water intake are you doing. There are apps for as there are apps that give you a lot of, I don't know what's the word, journaling. Like, so it's mood journaling, but you don't have to journal your thoughts. You just select what mood are you feeling from a list of moods that is given. Everything is like very simplified. The UI interface is very simple for the patient, so that there is less respondent burden, so that they don't have to type, or they don't have to feel like I'm sharing my feelings on a on an app which can leak my data. It's just selecting some things that are from an option that is given to you. So these apps are very readily available. It's just that if you want to use it in therapy, I would always advise a particular type of screening process to have before suggesting these things to the patient. One best way to do is, there is something called mindapps.org. I will just put it up in the chat, but I will send it as a resource also. Mindapps.org, which is a website that is made by, again, John Torreson and team at Harvard, where you can put in the filters that you want to have in an app for what disorder. Filter it. You will get a list of apps, and you will know whether they are free, whether they are scientifically validated. There are raters who have used that app and rated that app based on all the parameters. That is, there is a evaluation framework given by American Psychological Association for such apps, and they rate these apps based on that framework. So this is the only known app repository which is scientifically rated that I have known in how many years I have been in this field. And if you are a therapist and if you want to select an app, this is the best resource to give. So if you're suggesting, there are a lot of these outcome tracking apps, and there are a lot of these cognitive rehabilitation apps which you can select to give to patients to use cognitive exercises, which is also very useful. And that is another type of outcome tracking, because if you are giving any interventions, and if you're assuming the cognition, the outcome, the ultimate goal is the patient's cognition should improve. For example, in a lot of patients with negative skin symptoms in schizophrenia, social cognition is one of the main things that is affected. So we give a lot of cognitive training, and we give a lot of cognitive assessments that we always can't do it in the lab. So we give them in the form of an app, and with the hope that within 6 months we will see a change in cognition over a period of time. So these types of apps are there. How you integrate it depends upon your screening process, and how frequently you integrate it depends upon the patient's level of comfort as to how much do they want to use the app. Are they comfortable? Do they need any help from you, etc.?
Okay, that's good. So Soumya, after this webinar, can you also give us some of the criteria that Mind Apps or APA has given us on how to evaluate those apps?
Sure.
So it's something that we can do as a therapist, or even we can tell our clients to say, hey, do this, try this before you try any apps. Use this criteria, right?
Yeah.
So we are at 15-minute mark, and I did say we will start taking questions from other people. So there are a few questions that have come up, but somebody sent me question ahead of time. We are going to start with that. That has not come into the chat. That is, this is from a practicing therapist, and they say that the clients are actively engaged with me, but between sessions, they go also try out various different apps. It could be for mindfulness and meditation, or it could be for cognitive, learning. It could be even for mood journaling, whatever. So they come back and they are like all excited. I tried this and I tried that. But the therapist knows that these apps, their privacy issues are not there. The exercises that they give are not research backed or not validated. But at the same time, they don't want to discourage the client because they are so eager in trying out all of this. So how do they tell them gently to stay away and use something else? How do you do that?
Very good question, because we face this on a daily basis. And I always love this because a lot of the tools that I'm always learning from my patients, I'm only always learning from people around me about these apps, because it is so hard to catch up, right? It's always evolving and you're running out of time. One of the best ways to do this is to, first of all, never discourage them for using any sort of app that they're doing to make themselves feel better. Validate their experience. Always ask them that that is great, that you're doing something to make yourself feel better. How, ask about their experience. How has it been going? I like that you took this initiative, and after you're done with encouraging them for that initiative, validating their experience, asking them about it, gently introduce the concept of evidence-based tools into their probably thought process. That is that probably saying something like, I really like that you've done this to make yourself feel better. Is there any information you have on the effectiveness of it or the data privacy aspects of it? And if they have a solid answer, then let them continue using it. Maybe you can do your own research behind the scenes, just to make yourself feel better that, okay, your client is in safe hands. If not, um, if you feel the patient is not really sure of the type of app that they're using, and you feel like it might be a little under the gray umbrella of privacy and other things, you can introduce the concept of an evidence-based tool, saying that, I really appreciate that you've done this to yourself. Along the similar lines, there is another app that I have found to be resourceful and useful in your situation, which is similar to what you've been using and is evidence-based. Would you like me to suggest that to you? And maybe if the patient is interested, they'll say yes. If they're not, they'll just probably not. And then in the next session, bring back the idea of it. It is very important that the autonomy of choosing the digital tool lies with the patient, because it's a matter of consent. It is a matter of sharing their data on a daily basis outside of the therapeutic alliance as well, like when they are in their natural environments. So the autonomy should lie with the patient. But as a therapist, if you feel that it would be better to use an evidence-based tool, you can introduce that thought by either suggesting something that you feel is evidence-based, or asking the patient to either look it up, or just to make sure that these are effective.
Okay, that makes sense. That makes sense. Thank you. Another question from the audience. If one day we do develop an AI technology that can substitute human therapists, like the talking robots, how far will it affect the employment rates? And on the flip side, how much accessible will therapy and mental health become to the masses? That's a very good question.
I do not think that AI will ever substitute human therapists. It is a fear mongering notion that probably tech companies have created, that this is going to be the future. It will not, because there are there is something called a therapeutic bond, a therapeutic alliance that a therapist has with the patient. There is unconditional positive regard. There is no judgment. There are no biases. There is cultural sensitivity, because as a client, you would like to choose a therapist who's culturally sensitive to you. There is a lot of understanding between the patient and the clinician. Such things are absolutely not possible with AI. Even the latest model, I'll give you an example. I think Vedahi has asked this question. Is there was this very massively funded robot in the UK, which failed to answer questions about child sexual abuse. So somebody needed help for being abused. Some child needed help about some sexual abuse, and it gave very inappropriate replies. And the UK government deemed that particular chatbot unfit for use in the UK. And it was supposed to be very advanced, very active. There was another chatbot, I was reading about it, where somebody was seeking help for BDD, which is body dysmorphic disorders, and they gave weight loss advice in return to the patients. So I have no doubt that AI will never replace human substitute, simply because that touch is not possible with any sort of a bond. The new term that we are reading about is something called digital therapeutic alliance, where if you need some sort of a therapy from the chatbot or from ChatGPT, AI, or any sort of a thing, you set your own goals. You don't expect any goals the AI to set, because in a therapeutic bond with the actual therapist, you will jointly set your goals with the person. Here, there is no goals, no boundaries, nothing, right? With an AI. So you set your goals, which are objectable, like, just sort of giving you positive affirmations about something, the AI will do it. Giving you psychoeducation material on how to sleep better or sleep hygiene, the AI will do it. Those types of objectable facts that you need from a patient when you need from your chatbot when your therapist is unavailable, for those situations maybe it can be useful, but not completely substituted. So therefore, no, nothing to do with employment rates. If anything, it will only help with therapy and mental health becoming more accessible to the masses, because there will be more channels where people can seek help, as compared to sitting on a train traveling to NIMHANS, sitting on a train going to Delhi, or going to your local therapist who will have a 6 months of probably waiting. You will not get that care if not with a smartphone, because smartphones are the number one best way to reach people. So if you integrate AI, if there is a time when AI is anything but the most normal thing around, it will help with the proper care reaching, if used in the correct manner, with the proper care reaching the masses, and the masses feeling more empowered to seek care, stigma coming down. We only had a national mental health helpline in the year 2022, which is 2 years post COVID, because COVID sort of highlighted how much how much the country needs mental health help. And using telepsychiatry, using these services, we have made sure that the help reaches everybody who needs it.
Right. While you take a sip, I want to also address Shreyas's question, which is way down the line, but it relates to the answer that you have already given. I think that AI assistance directly going to clients, it will not replace therapy. It will not replace therapists. In fact, when we talked about AI assistance before, it was for therapists to use it as an assistant so that they can get more data. So, Shreyas, if you believe that whatever Soumya has already answered your question, then we will skip that. But going back to another question, what are the measures to ascertain that the clients are empowered by using any of the digital tools? Is there a standardized framework, and are they measured and reported?
This is where your clinical judgment comes into picture, because there is something called an app usability scale, which is you can use to know how much are they liking the use of the app. Probably that's something we use in the hospital with MindLab. That helps us understand, did they like the app, would they like to use the app again. But whether they were empowered or did they feel better using these apps will rely on two things: what the patient reports to you. If you want to go one level extra, you can ask the caregiver what the caregiver is reporting to you, how the patient probably tells the caregiver that they feel using this app. And the third is your own clinical judgment of how the patient is doing with the app. If they are improving the way you want them to improve, if the trajectory of improvement is good with the use of the app, then it's probably doing its job. Or but there is no way to know whether it is the app or the therapy. Like I spoke in Manotsava, that it's very difficult to have a control group for such things, because you would give therapy and then jump to the app, and there is no way to have another scenario where what is the control group for an app. Like, is it a blank app, is it no app? So the research is still struggling on understanding how to make these control groups for such side of studies. But the three things that I was mentioning is A, what the patient report, what the caregiver reports, and how you feel as a clinician that the patient has felt with the use of the app. Most of the patients that I know want to delete the app the minute they are done with it. So that way I know that it's probably not the best to ask them to continue using it. So that is just the clinical judgment that you have to use. But app usability scale is one such framework that I know can be used.
Okay, all right, thank you. There's another question. Previously, you mentioned that there are different purposes for the apps, right? You
Mhm.
mentioned three purposes. One is outcome tracking, another is symptom tracking, and the third one is peer support. What are the apps in each of these criteria, probably, which do a good job of what it's meant for? Do you have any idea? Can you go a
Yeah.
little deeper into
Sure.
it?
So outcome and symptom tracking is something similar. Peer support is one. There is cognitive rehabilitation apps. There are other apps for mood reporting. I think I spoke about mood reporting apps and journaling apps. That is another type. Apps do a good, the way we measure how well an app is doing, is by engagement. How much people are engaging with the app. If they're engaging for longer periods, that means they're actually finding it useful, so hence they are engaging. And the largest amount of engagement, as I had mentioned probably towards the earlier side of the call, is with peer support apps. So where you can actually talk to a therapist or get some sort of an immediate help from a therapist, connect to a peer support, are the types of apps that are probably having a little more than a small effects and moderate effect sizes, which is like it's impacting, significantly impacting a moderate population in a positive way. So that is something that is doing best, and others have small effect sizes. So in terms of engagement, if you look at it, peer support are the types which are probably having a better impact than other types of apps, but it is very closely followed by all the others. So like if you engage with peer support app for 30 days, you're engaging with the other apps only for a period of 13 to 15 days. So that is what the research says. We haven't had but that, which brings me to another very important point, is a lot of studies in this field which is done in digital psychiatry. Whenever you read such studies, you should always look out for two things. First, what is the sample size? Because a lot of these studies are done with small sample sizes, 20 people, 30 people, 40 people, 60 people at max. And it's a very small sample size to make generalized outcomes, our generalized results, and say that okay, 60 people who had schizophrenia got better with an app. That means the whole population of schizophrenia will get better with the app. So that is where the effect size comes in, and these are all small effect sizes studies. The second problem with these with the research done here is nothing is longitudinal. So either it is a cross-sectional use of the app, which is 30 days, either it is a probably 60 days use of an app. There is no app that is used for 1 year or 2 years or 5 years, etc. So the duration of the app use and the sample size are the two things that are problematic in this field, and hence most of what we know comes from a small sample size of people who have used any app for about 6 months at max. So we don't really know what are the long-term benefits of such apps, yearly benefits or something that people have continued to use over 1 year or 2 years. So when Advait, when you ask me what is doing a good job, from what data we know for a pilot study in small sample size, we know peer support apps do better simply because people engage with them longer, but we don't really have, the field in general doesn't have longitudinal data for me to give you any answer.
I think it will take a little bit more time
Yeah,
and more efforts from therapists to,
correct.
encourage such peer support
Correct.
apps, right? So before we kind of wind down, when you say these peer support apps, is it peer support where the clients are talking to the therapist, or does that also happen in apps where the clients are chatting with the therapist? Is there
Mhm.
any differentiation? I'm sorry, I'm catching you a little off guard with this, but do you know of any differentiation between the two?
Between peer support and
In the peer support, whether they are talking, the clients are
right.
talking to the therapist, or whether they are chatting to the therapist.
I think peer support would mean that there is a physical person. So
Mm,
it can either be talking or chatting both. So
mm,
it is some sort of support coming from a peer, any form of a support that can be coming. That level of detail, I don't even think that that's there in research. But I would like to clarify again. But peer support apps have the highest level of engagement as compared to other apps. So that is the only metric we have for now to tell that okay, this is people are using these apps longer, but that does not necessarily mean that they are better than other apps. They're just, people are just engaging with them more.
More, yeah. Sorry, just one more question from George. You said that patients use an app and immediately delete it after they are done with it. Do you think it's because of stigma? Is that the reason, or is there some other cause, or can we change why they are the behavior where they delete the app?
Correct. So it's not stigma. It is just simply because they see no use. Or they have not benefited from the app, and that is why they don't want to engage with the app anymore. And that is why engagement is such an important metric to determine the effectiveness of an app, because you know that the person is seeing some benefit from it, so that's why they are using it. Most of the patients that I am talking about that they want to delete is because they have never it's also about the content of the apps. If they feel like it's the same content getting repeated every week, which is true, because we are trying to cognitively train them on the same exercises for about 3 to 4 weeks and measure them on the same one for 4 weeks. So they get bored of it because they say, ma'am, this is something that I've done last week. I did it for like, this is the same thing I'm going to do next week. There's nothing new in it, so I'm bored of it. The second thing is that they don't see any benefit from those things. We can change one of the causes we can change is change the content more frequently. But then the challenge with changing the content is that we need standardized content on it, and getting standardized content on the app itself needs validation, which is another pilot study. So that is why it's a loophole, a negative cycle of going round and round. That's why we need more time for resource building of such apps.
So, should we then wait until the research, because you will not have the results without the apps, and you cannot use the apps or encourage the use of apps without the results. It seems to be a cyclical problem.
It is, and that's with every field. It is any field that is new and upcoming. When cancer research was coming up, it was a similar dilemma. With when any type of pharma research comes up, it is a similar dilemma. In any sort of research, this is a similar thing. We just have to continue doing whatever research we can with how many ever people in whatever methodology, as long as it's consented, it is safe for the patients. They have the right to withdraw, that they want to stop using this app. You have to stop using the app. They have the right to delete their data from the study. Any ethical research guidelines, as long as that is followed, the patient is consenting to those guidelines, then we should continue to do the research and definitely continue using the apps.
Okay. So we have run out of time, but before we close, is there any final thoughts from you, Soumya, on the future of digital tools and mental health? Any parting words?
It is definitely the future. There is no doubt about it. If I have sounded pessimistic through the talk, I'm not. I am dedicating I've dedicated my last 5 years. I'm going to be in this field for the next how many years I am a psychologist, because I see potential in this field. It would be a very ignorant thing to say that I can manage without adapting to the technologies coming in. I can't, because it is the need of the hour. It is going to be in everyone's phone, and it is one best way to reach people is smartphones. And I know that there's a lot of skepticism around it, because there is a lot of issues regarding confidentiality. There is no body that regulates this. No, you have somebody regulating ICMR is the controller of drugs. FDA is the controller of drugs in the US. You have bodies that regulate medical devices. They regulate drugs. They regulate medicines. There's bodies that regulate doctors. There is the RCI for psychologists. There is the Indian Medical Association for doctors. Everybody has a way of being regulated except these apps. There is no way to regulate these apps, and we are actively suggesting these apps to patients, and we are telling them that it's useful, it's evidence-based, but there is no oversight to these. If we have a way, if with the upcoming Digital Data Protection Act, DPDP Act, with Indian government taking more cognizance of that need for AI regulations in medical devices regulations and apps regulations, etc., with the Ayushman Bharat Digital Health Mission, with all of these digital infrastructures coming together, then I feel that India will be very well positioned to use such apps. I'm also actively working to improve digital literacy in the populations. If we can improve the use of smartphones by giving more digital literacy programs at NGOs, organizations, to anybody we feel is not privileged enough to know how to use a smartphone, etc. If you can do that for from your own homes and contribute to improving India's digital literacy, having if we do these two things, then India will be very well positioned to use these apps, and more people will get help from these apps, and in turn the global health burden that we have in India of mental health disorders would reduce. So it is definitely the future. I would maintain a balanced approach. If you're a clinician using AI, using any sort of an app, please make sure it's scientifically validated. If you are a therapist who's actively promoting apps on social media, if you're putting psychoeducation content out there, please make sure that you do follow a social media policy where you're not actively suggesting apps that you know are shady or come under the gray umbrella. Just take an active responsibility as a clinician when suggesting those apps so that you know what you're suggesting is right, and definitely adapt to them with time in a hybrid model possible. So those would be my parting comments.
That is very optimistic, and I hope your vision for this digital mental health in India comes true in a secure manner, Soumya, because that is the most important thing, in a safe, confidential, secure manner. Thank you so much, Soumya. You have been an amazing treasure trove of knowledge. We appreciate you taking the time out of your busy schedule to come talk to us.
Thank you. Thank you so much, Veda. Thank you for having me here. And thank you to all the audience for such great questions. It was really nice talking to you all. Veda can leave my email on the YouTube channel. If any one of you have any questions further, please feel free to write to me, and I'll definitely share the resources that I have mentioned in this talk.
Yeah, the audience have been very interactive and a lot of very good questions from them. So thank you, audience. We really appreciate all of your participation, and we will see you at the next Zensible webinar. Have a good evening.